in acute toxicity cases, which usually happens due to accidental or intentional overdosing of these medications, or plants or fruits which contain the cardiac glycosides, the patient will usually having more of GI symptoms. So in acute toxicity, patient will be having more of pronounced GI symptoms compared to chronic toxicity. The patient presents with nausea, vomiting, anorexia, abdominal pain. The patient can have cardiac manifestations, and bradyarrhythmias and AV blocks resulting in bradyarrhythmias are more common in acute toxicity compared to chronic ones. Now, the patient can also have weakness as well as confusion. It can result in something called as a classic Xanthopsia, which is finding of yellow-green halos around objects. Some patients might even complain of that, but most of the times it's hard to say this exact yellow-green halos. They might be saying there is some problem with the color vision. Okay. Now, hyperkalemia is one of the important findings in acute toxicity, and it has a prognostication implication as well in acute digoxin toxicity. Now, we know that digoxin acts by inhibiting sodium potassium ATPase pump, right? So what it does is it increases the intracellular sodium concentration and it increases the extracellular potassium concentration, which results in the hyperkalemia. Okay, but hyperkalemia is usually seen only in acute toxicity. In most of the chronic patients who are on digoxin for a long period of time, their kidneys, if they are functioning well, will reduce the potassium level by secreting more potassium through the kidneys. Alright, so usually chronic toxicity patients will be having either normokalemia or sometimes they may even have hypokalemia. Okay, so hyperkalemia is one of the most important findings in acute toxicity, and the severity of hyperkalemia is associated with high mortality. Now, one more thing you need to remember is that the hyperkalemia here is not the reason for the high mortality. The hyperkalemia indicates, the severity of hyperkalemia indicates there is more severe digoxin toxicity which is responsible for the mortality. Why I'm saying is that even if you correct the hyperkalemia with all the anti-hyperkalemia measures, the mortality is not going to improve unless you correct the digoxin toxicity. Alright. Now, in chronic toxicity, the patients are usually elderly patients already taking digoxin for a long period of time. Now, what pushes them into this toxic state? You need to think about three conditions. First of all, there could be some condition which could have resulted in a decreased renal clearance of this drug. Okay, for example, in our patient, he was having diarrhea and he was having volume depletion. This could have resulted in acute kidney injury and decreased urine output, which leads to digoxin toxicity by more drug being concentrated in the body. Because digoxin is a drug which is eliminated by the kidneys only. Alright, now the second thing you need to consider is electrolyte abnormalities like hypokalemia or hypomagnesemia, or both may be present. If you remember this patient, our patient is on furosemide. Furosemide can result in hypokalemia as well as hypomagnesemia. He is also having diarrhea, which can also result in electrolyte loss. Okay, so that could have also precipitated toxicity in our patient. Now, the third thing is to think about drug-drug interactions. See, digoxin is a drug which is usually extruded from the body or excreted from our body using something called as the PGP protein or P-glycoprotein. It's usually secreted into the GI tract as well as into the kidneys through this protein. There are a lot of drugs which can interfere with the secretion of digoxin by binding to this protein. Macrolide antibiotics are notorious for this. Okay, so erythromycin, clarithromycin or erythromycin, if the patient has been prescribed for some other conditions, it can cause drug-drug interaction and decrease clearance of digoxin from the body. Now, a lot of other drugs can also cause digoxin toxicity like calcium channel blockers, beta blockers, class 1A and class 1C antiarrhythmics, then furosemide like I already mentioned, all these things. Okay, all these drugs. So you need to think about all these conditions which could have precipitated the patient and pushed him into digoxin toxicity. Okay, now in chronic toxicity, the clinical presentation is very much vague. They mostly present with less pronounced GI symptoms. They might be having some nausea, some vomiting, some abdominal discomfort, but most of them present in a confused state or some sort of altered mental status. Alright, so whenever a patient is on digoxin and he presents with any kind of complaint, you need to think about digoxin toxicity. Now, this is a very nice table which I have taken from the textbook of emergency medicine called Tintinelli, which differentiates the various presentations of and the various findings you can get in acute toxicity versus chronic digoxin toxicity. Just one of the things which I have not previously mentioned is that chronic digoxin toxicity is associated with more of ventricular tachyarrhythmias. You can have any kind of arrhythmias in digoxin toxicity, even bradyarrhythmias in chronic digoxin toxicity, but ventricular tachyarrhythmias are more common in chronic digoxin toxicity. Alright.